This meeting is being recorded.
Good afternoon, everyone, and thank you for joining us for our CDC Dental Public Health Lecture Series. Next slide. My name is Gina Thorne-Evans, and I'm the Director for the CDC Dental Public Health Residency Program, and also the team lead for surveillance, investigations, and research in the Division of Oral Health at CDC. Next slide. The purpose of these lecture series is designed to help current and future dental public health residents gain a better understanding of the 10 dental public health competencies and of current events in the field. These webinars are for current dental public health residents, prospective residents, and anyone interested in the field of dental public health. Each lecture will feature experts in dental public health to provide a deeper dive into their experiences and each competency. Each webinar will be announced via email, and the date will also be posted on our website a few weeks in advance. If you would like to be notified about upcoming webinars, please scan the QR code on the screen and subscribe to the Dental Public Health Residency Program email series. You can also click on the link in the chat. Please feel free to type your questions into the chat box and we'll answer them during the Q&A portion at the end of the presentation. Next slide. By definition, dental public health is the science and art of preventing and controlling dental diseases and promoting dental health through organized community efforts. It is that form of dental practice that serves the community as a patient rather than the individual. It is concerned with the dental education of the public, with applied dental research, and with the administration of group dental care programs, as well as the prevention and control of dental diseases on a community basis. There are 10 competencies that define the knowledge and practice based on the development by the American Association of Public Health Dentistry and the American Board of Dental Public Health. Next slide. Today, we're fortunate to have Dr. Bruce Dye as our next lecture presenter. And Dr. Dye is the Delta Dental of Colorado Foundation Chair in Oral Health Equity and the Professor and Chair of the Department of Community Dentistry and Population Health at the University of Colorado School of Dental Medicine. Dr. Dye graduated from Ohio State University with a DDS degree, earned a Master of Public Health from the University of Michigan, completed a U.S. Public Health Service Epidemiology Fellowship with training at Johns Hopkins University, and a dental public health residency at NIDCR. He began his career in the U.S. Public Health Service, working in Indian Health Service clinics and hospitals in South Dakota and Michigan as a clinical dentist and program director. Later, he worked at the National Center for Health Statistics as the dental epidemiology officer for the National Health and Nutrition Examination Survey. More recently, he was a dental epidemiologist and director of the Health Informatics and Dental Public Health Fellowship at the National Institute of Dental and Craniofacial Research, which was in partnership with the National Library of Medicine. Dr. Dye's work has focused on epidemiology of dental diseases and related conditions, research methodology, and public health informatics. He has collaborated on several studies and survey operations, both nationally and internationally. And more recently, he was the project co-director and scientific editor for the new NIH report, Oral Health in America, Advances and Challenges, the follow-up report to the 2000 Surgeon General's report on oral health in America. I would like to now turn it over to Dr. Bruce Dye.
Thank you, Gina.
for that kind of production. It makes me think like I need to retire and find a nice island to go move to. Well, thank you everybody for joining me this morning or this afternoon, depending upon where you are. Before we get going, I just want to let everybody know that in my traditional fashion, I have a lot more slides than what normally would be used in a presentation. So some slides I'll be whipping through pretty fast, but I hope you find it enjoying. So the plan for the next hour or slightly less than an hour is to just put a couple things in the context very briefly and remind you why it's important. Then to talk about a tale of two populations. Then let's visit a little bit about healthcare delivery and supporting resources in the United States and how those are changing. And oral health care is essential, but is that good enough? And when we think about those things, those three things together will come together to the 5 themes that I'm hoping to get across. So in the last couple of decades, we've had 2 reports on oral health in America, and yet progress has been inconsistent. Both reports talked about safe and effective measures that exist to improve oral health and prevent disease. But why have we not experienced significant progress across for all populations? In the introductory level to the 2021 Oral Health in America report, the letter that was written, signed by Dr. Murthy, our Surgeon General, and Dr. Francis Collins from the NIH. There was one area in the letter that's really important and it needs to be brought out and highlighted, and that is people in the United States experience oral health differently. Why do people experience oral health differently in the United States? Well, we have those individual factors that continue to play an important role in oral health, like toothbrushing, diet, behaviors with regards to oral hygiene, visiting the dentist. But another important factor is related to societal factors, and they play a broad and important role in oral health. And we refer to those as social determinants of health. So let's dive into one of the big things that is really influencing oral health in America today. First thing is pediatric dentistry, specifically the decline in untreated tooth decay in children. Before we undertook the report in 2018, we went back and we looked at some of the historical record of how was the 2000 report built. And one of the interesting things with regards to data and how data was used to inform the 2000 report is that most of the data sources coming and feeding into the 2000 report actually was collected and synthesized in the late 1980s. When we think back about caries in the primary dentition in preschool age children, we can go back to the 1970s and we can see that the prevalence of caries was around 1 in 4 for children under the age of 5, and then untreated caries was about 1 in 5 or 20%. And then the information that was used to help generate the 2000 Surgeon General's report, that changed very little. And one important thing just to point out, when we think about untreated caries is considered a good proxy for access to care. The 2000 report and the 2003 follow-up, the call to action, focused on highlighting the importance of collaborations and how collaborations can be used to help inform policy discussion, advance policies, and actually help improve decision-making. In the area of pediatric dentistry, collaboration was very important in the early 2000s. Those collaborations helped to work in three distinct areas: in public policy, especially collaborations helping to advance congressional efforts to reauthorize CHIP, for instance, expanding Medicaid funding through the ACA, and also increase funding for community health centers to improve access to care. On the professional societies policy level, activities by the ADA, APD, and AAP all helped to create the concept of help to mobilize everybody to recognize the importance of early first regular dental visit, that is by age 1, to advance the concept of dental home, developing clinical guidelines for risk-based dental caries prevention and management. And then on education and training policies, there was a lot of activity recognizing pediatric dentists as primary care dental practitioners. And this increased funding through HRSA for training pediatric dentists. And this also helped pediatric dentists to become the point of care for children with special health care needs. And this increased the demand for pediatric dentists to treat underserved pediatric populations. This graph just simply shows, if you look at the red bar, you can see the dramatic improvement in the number of PEDA residents being trained and then later working as pediatric dentists in the workforce. That is significantly more compared to the other specialties in the United States in dental practice. Now, returning back to the graph where we were looking at caries experience and untreated caries, in 1999 to 2004, shortly after the 2000 report was released, there was a lot of activity directed at trying to advance policy and implement new activities at encouraging younger children to go to the dentist. And then we can see after all of those activities, that is creation in the dental home, motivating children to see the dentist by age 1, increasing access to care by increasing coverage. All those activities dramatically had an impact, and that impact was on untreated caries, where the prevalence of untreated caries was reduced by half. However, the prevalence of caries experience changed very little. One of the important advances with regards to those young children is that the children, when we stratify children into how they live in their household versus poverty and those who are non-poor, we can see that the disparity that existed before those activities was much greater than the disparity now. So those activities that helped guide and encouraged more children to visit the dentist, where we saw a reduction in untreated decay, that reduction was significant. And so the new disparity is much less than the old disparity. And this is particularly bears out when we look at the proportion of those surfaces that are filled versus the proportion of the surfaces that are not filled. If you look at the center 3 panels, the panel on the left represents children aged 2 to 5 that live in poverty. The panel on the far right represents children who live in households that are non-poor. Those are living in households at 200% of their poverty guideline or higher. We can see the crossover, the 2 red circles. This means that the difference between the proportion of untreated versus the proportion of filled has dramatically changed to where there are more surfaces that are filled and surfaces that are untreated. And that proportion is exactly the same for those living in poverty and those who do not live in poverty. So this is a fantastic example of the elimination of a health disparity through all those actions. Now, if we think about the other population, the other spectrum of the lifespan, geriatric population, the most persistent challenge is access to care. And this is really important as we consider that the world is aging. Demographers look at fertility rates, and they have this concept called replacement level. And for a population to remain stable, we need to have the fertility rate needs to be approximately 2.1. If you look at the chart here, and you can see the yellow, which represents 2020, the blue represents into the future, I believe about 2050. We're already in North America, we're below the replacement level. So many parts of the world is living, except for Africa, is living in an aging world. And most of the world will experience a shift in aging population increasing. When we began a report in 2018, the Census Bureau was estimating that by 2035, there would be more older adults in use in the United States. Well, that estimate has now been revised to 2034. And this is important because it reflects an important concept in demography called the dependency ratio. The dependency ratio basically looks at the working age population and compares that to old age and youth. And that proportion needs to be relatively stable because the working age population supports the older age and the youth. And this is really important for us in the United States, especially when we think about dental insurance, because dental insurance isn't employment-based. So as the dependency ratio changes, where the working age decreases and more older or much younger people are increasing, fewer working age folks will be supporting older and youths. The Global Burden of Disease study has brought a lot of important information to us, and we all can probably remember that important number, about 3.5 billion people that's affected by an oral disorder, and the number one prevalent condition is untreated caries. The graph over the left breaks out oral disorders by prevalent cases globally, and the graph on the right compares that to the United States. And you can see when we look at oral disorders, dental caries is very important. The x-axis is age groups, and as we age, you can see the changing colors. So blue is caries, the light green is perio, and the darker green is edentulous. So as we age, edentulous and perio becomes more prevalent in the United States. This is a similar concept with burden, but we're looking at living with disability and years living with disability. And when we no longer look at prevalence and we look at disability, we can see a dramatic change in the burden of disability as it relates to oral disorders. So now that edentulous, the darker green, dominates and is responsible for most of the disability when we look at years of with disability. Whereas the dark blue there, which is very, very small, represents disability as a result of dental caries. There is more disability resulting from periodontitis than there is from dental caries. And this is an important concept. Another important issue affecting oral health status in older adults is edentulous is declining and continues to decline. And maybe by the next 5, definitely within the next 10 years, we may be below 10%, maybe even approaching 5% of the population age 65 to 74 who will be edentulous. And this is important. As we're reducing the amount of edentulous and more teeth are being retained, these teeth are at greater risk for caries and periodontitis. This graph shows the prevalence of periodontitis in the United States, and that red little bar shows the prevalence of severe periodontitis among older adults. So you can see that in the United States, about 60% of older adults experience some form of periodontitis, and about 10% experience severe periodontitis. When we think about that in comparison to untreated caries, the orange bar marks the prevalence of untreated caries in the United States, and we can see that prevalence of periodontitis is still significantly higher than the prevalence of untreated caries in the United States. When we think about the DMFT index and which component drives the DMFT index in older adults, we can see that the dark green, which is missing, is substantially higher than the darker green, which is the untreated caries. When we think about folks who live in poverty, those who are poor, missing is the most significant component of the DMFT. Whereas in the non-poor, having restorations or fillings, the F component is the most significant part of the DMFT. Where older Americans live in the United States depends upon the prevalence of tooth loss, especially tooth loss when we think about having 6 or more teeth missing. And folks living in older adults living in the United States, tooth loss is more concentrated in certain areas. An important factor with regards to tooth loss in older adults is that while older adults are keeping more teeth, which is good, and it's good because when we think about having 21 or more teeth, we're having a functional dentition, prevalence is increasing, and the prevalence is increasing dramatically, especially among those age 75 and older. This is really important because we know from research that having a functional dentition is tightly correlated to having improved quality of life and well-being for older adults. However, when we look at functional dentition, we can see that not everybody who's age 65 and older is benefiting from an improvement in tooth retention. The blue bars represent those older adults who live in households where at twice the level of the federal poverty guideline. The purple is those who live in poverty. And we can see that back in 1980 to 1994, when we were looking at the prevalence of having a functional dentition, the disparity between the non-poor and the poor is smaller than it is now. So while all older adults are benefiting from having retaining more teeth, only those who are non-poor, those who live at least twice the level of federal poverty guidelines, are really benefiting from having a functional dentition. And that rate is exponentially increasing compared to those living in poverty. So this is a great example of where there's been improvement across the population in total, but we're witnessing an increase in disparity rather than a decrease in disparity. Other issues affecting older adults, it's very important, is that older adults, as we all know, lack dental insurance coverage. More than half of all older adults do not have some form of dental insurance coverage, and cost continues to remain an important concern for older adults when obtaining dental care. Out-of-pocket dental expenditures have decreased for youths, but yet have increased for older adults. And this is really remarkable given the fact that we have increased access to care for children in the United States. And that increase in access to care has actually helped reduce out-of-pocket expenditures for parents, whereas there's been no increase in access to care for older adults. And this has resulted in a higher out-of-pocket dental expenditures for them. And the largest increase in total dental expenditures have been for older adults in the last couple of decades. So if we think about the third theme, or thing number 3, think about technology advances. And this all comes under the area of care delivery and resources, and how these things are really changing and transforming, and the complexity around them is occurring. The advances in science and health technology in the last 2 decades have been really substantial. It has helped improve our understanding of the biology of oral disease, and some of the discoveries, particularly around the microbiome and genomics, have been really enlightening. We now have a much better idea about the role of bacteria in health. This comes to the notion of dysbiosis and about balance and about how it's important to keep the microbiome in balance. We have a greater understanding about inflammation, processes behind inflammation. And this is really important because one of the most important findings in the last 2 decades has been the rapid increase in our understanding about the relationship between, say, periodontitis and other systemic diseases. Today, we know there are more than 50 conditions that have some form of association between periodontitis and those diseases, which is substantially more than what we knew in the year 2000. So inflammation is really important. We also have acquired new information around genetic mutations and how they affect oral and craniofacial conditions. And I think one of the more exciting things is improving our understanding around how the environment, particularly certain determinants like social determinants of health and genetic profiles, how they interact and help predict health outcomes. In this area, we call epigenetics. Other important areas have been advancements in using platelet plasma therapies, especially for the applications of tissue regeneration and dentistry that help reduce postoperative pain, promote tissue and bone growth. These have been really predominant in oral and periodontal surgical procedures and have been really helpful for older adults. And then the whole area of lasers has been really exciting. We now see widespread use of lasers in oral and perio surgical procedures. And in the near future, there's great promise that lasers will replace the high-speed handpiece to remove caries and to help with restorative preparations and so forth. We have advances in biomaterials. One of the more exciting advances in my mind is related to the transition from using titanium implants to ceramic implants, especially for single place implants. And then all the advances around bioresins and 3D printing and processing, which helps to create custom dentures, crowns, and tooth aligners and same-day procedures, for instance. And as we all know, there's been a rapid evolution in the implementation of digital technologies. Dentists love their digital gadgets, and we see this rapidly being implemented and applied in dental practice settings. Anything around imaging, for instance, intraoral, panoramic, cone beam technologies, tomograms, all rapid advancements in use and application in dentistry. A couple of other areas that we're starting to see increased use is in the area of AI, or augmented artificial intelligence. And we're using artificial intelligence to help improve accuracy of diagnosis and to identify care pathways. It's not just in dentistry, but in a number of medical professions. AI is helping to identify, to read and identify, but to use a screen processes with the application of the digital radiographs. Virtual reality or augmented reality is something that's new, and I really think we will see a much greater use of in dentistry. And the promise of virtual reality is to relax patients, to reduce pain sensory, and to improve the dental visit experience. In other words, for all those dentists out there who still have ceiling mounted televisions, it's time to get rid of them. But digital technologies will continue to have an oversized influence on oral health in the near future. We're going to see this from the transition from the electronic dental record to the electronic health record. We're going to see this in telehealth and teledentistry. We're definitely going to see this in the processing and fabrication of restorative materials. We're going to see this in the use of imaging and diagnostic applications. And we're going to see this in technologies that's going to monitor behaviors and hygienes and provide direct user feedback. In other words, the smart toothbrush. But there's an important elephant in the room when we think about technologies in dentistry, and that is in every industry but one. Technology makes things better and cheaper. We want to advance science, develop new technology and methods that improve our lives, but these improvements come with a cost. Just because some aspects of healthcare cost more does not always make it better healthcare. And this paradox between cost and technology is what we must constantly remain vigilant for and try to prevent. Because if we're not careful, this paradox will make health disparities worse. And in many ways, we see this in the older adult population. Implant prevalence is up for older adults. Older adults want to use implants, but only those older adults who can afford implants are benefiting from implants. And this is creating a greater disparity. The fourth thing I just wanted to bring out to talk about that's influencing oral health is workforce and finance challenges. We're all familiar with the health professional shortage areas in dentistry. When we put this report together, there was more than 5,800 DIPSs in the United States, which affected about 60 million Americans. Health professional shortage areas is one reason that impacts access to care, and this drives some of the initiatives with regards to changing the models of care in the dental workforce. What we're seeing is new providers coming along in the last couple of decades. For instance, physicians and nurses delivering more oral health services. We've seen the introduction of community health worker coordinators or community dental health coordinators, and then dental therapists. We're also seeing a change in settings where oral health services is delivered in order to expand the opportunity for people to access those services. Some of these are within schools. We've seen this with teledentistry. We've seen this in primary care medical practices, particularly within pediatric practices, and then changing in how dental is delivered from more solo practices to group practices, which I'll mention shortly. When we think about the oral health workforce, it's important to think about dental hygienists. And dental hygienists in the scope of practice greatly by state. And this has an effect on access to care. A couple of things I just want to bring out. When you look at this wheel, which I think is a great visual representation of to try to provide like an overarching perspective of the scope of practice and how states differ. You can see that some states have an expansive list of scope of practice, whereas others are not nearly as progressive. You look at the outer ring, you can see there are a few states here, which I think is important to point out. For instance, the state I'm in, Colorado and Oregon, have very large expansive hygiene practice, scope of practice acts. Other states like Minnesota and Vermont and Maine are pretty substantial as well. Interestingly, these states that have extensive scope of practice for dental hygienists are also states that have authorized dental therapy for some level. But California is the only state that actually has a dental hygiene board where hygienists regulate the practice of hygiene. And when we think about some of the scopes of practice and some of the interesting things that may not line up with how dentistry is practiced today, we can see that there are some states, for instance, that do not allow hygienists to administer local anesthesia, whereas other states will especially prohibit hygienists from using lasers, and some states don't have anything within the Practice Act prohibiting or acknowledging the hygienists can use lasers. I think for the state next door, well, almost next door to us here, Texas is interesting because Texas does not allow hygienists to administer local anesthesia, but Texas really does not care if hygienists use lasers. Another important thing that has emerged has been health professional well-being, and this is very important. Health professional well-being has been recognized as affecting quality and cost-effective healthcare. And you can look here on this diagram where there's 7 areas that affect clinician well-being. 2 of those, the health professional has more or less direct control over. These are personal factors and their skills and abilities. And then there's all these other outside factors that affect clinician well-being. But what's important is that clinician well-being is directly related to clinician-patient relationship, and having a good clinician-patient relationship is important for patient well-being. The impact of healthcare team burnout is substantial. For instance, health professionals who are burned out or not experiencing good well-being are more likely to overuse resources. They're more likely to prescribe more medications or inappropriately use medications. Burned out professionals are more likely to have lower levels of empathy. Malpractice suits are higher in healthcare professionals that are experiencing burnout. And health professionals experiencing burnout are more likely to move from job to job, where the profession is more likely to experience higher turnover. One of the more important things as it relates to patient care is that healthcare team burnout leads to higher costs, patient dissatisfaction, and poor health outcomes. So what does those 3 things remind you of? Well, hopefully it reminds you of the triple aim. I think Amanda Berkowitz and colleagues introduced a triple aim sometime around 2006 or 2008. And they were advocating that improving the healthcare system requires the pursuit of 3 aims concurrently. That is improving the experience of care, reducing capital cost of healthcare, and improving the health of populations. So the triple aim also is very applicable to the oral healthcare system. In the last decade or so, provider burnout and well-being has been recognized as what is now called the quadruple aim. And in order for healthcare systems to optimize the delivery of healthcare, reaching and achieving the quadruple aim is equally important. And you can see that the Agency for Healthcare Research and Quality supports the integration of healthcare provider resilience and burnout into the triple aim. And this helps to facilitate a more effective healthcare system. The 4 factors, when the quadruple aim is achieved, 4 factors that we hope to see is better outcomes for patients, improved patient experiences, improved provider experiences, and also importantly, lower costs. Cost of dental education is high, and this is something that we all know and have recognized. And dental graduate debt is very important because the high cost of dental education is an important factor in where graduates choose to practice. And speaking of high costs, dental expenditures continue to rise since around 2000, from about 95 billion to 162 billion over the last 2 decades. Where the more important question to ask that surrounds increasing dental expenditures are, will out-of-pocket expenditures continue to rise as well? Will private dental plan coverage and benefits decline as the working age population declines? Will public plans continue to grow in light of increasing government budget pressures? These are really important questions, and understanding how and what these answers might be in the next 5 years will have an important impact on oral health in America in the next decade. So I'm going to bring it back just very briefly to economics, macroeconomics in particular. And since dental care exists in the marketplace in the United States, another way of thinking about macroeconomics is to look at demand and elasticity. And the basic concept of elastic demand is that when the price goes up, the quantity or number of products delivered or services delivered goes down. So as the price goes down, the number of services increases, or the number of purchases increases because the demand picks up. So here are some examples of inelastic demand, at least according to what Google says. So it's important to recognize in the marketplace that dental care is affected by elastic demand and not inelastic demand. But here in the United States, Google tells us that gasoline or tap water or cigarettes and eggs, I think we all can recognize that eggs is very expensive today, and we still purchase eggs. These are a great example of inelastic demand. But in the United States, Starbucks coffee is also considered inelastic demand, as is Apple iPhones. I think this has a lot to do with marketing and monopoly. The total number of dentists working in the United States has increased since the first Surgeon General's report. And that number of increased dentists actually is working in fewer private practices. So the number of dentists working in private practices decline, and the number of those dentists who are actually owning practices is also declining. So our workforce is changing. It's stressed, and it's unclear how current financial trajectories will impact dental care delivery systems in the future. We have more dentists working in group practices, and we have a greater presence of DSOs. The fifth thing to think about is precision healthcare versus primary care. We spend a considerable amount of resources to develop innovative technologies to advance healthcare. And more recently, we framed our purpose for these advancements around the notion of precision healthcare and how this will help to lead to better outcomes for individuals, and how better outcomes for individuals will aggregate up to improve public health. But the real question is, can precision or personalized dental medicine lead to improved public health? We know that technologies can work safely in people, and we know that they can help cure and improve people's health. But the bigger question is, can it be reliably used in practice that leads to improvement in public health? The pandemic brought attention to the disjointment between medical and dental care and raised several issues. One of the more important ones is including that dental care is essential. But I think just saying dental care is essential is not enough. The challenge that we face is how we can implement changes that transform dental care into something truly essential. So what if dental care was truly considered primary care? Primary care addresses the majority of a person's health needs through their lifetime. It's more than just medical care, but it also includes physical, mental, and social well-being. And primary health care is person-centered care. It's not patient-centered care. This is an important distinction. Primary healthcare is also is about routine and regular healthcare a health provider gives. And primary healthcare is a regular point of contact with health services. We know that primary healthcare can improve health outcomes. It can improve health, patient self-rated health, improves their quality of life. It reduces morbidity and reduces all-cause mortality. So primary healthcare is considered essential healthcare. So what if dental care was truly considered primary care? United Kingdom, while primary healthcare is mainly provided by general practitioners, community pharmacists, opticians, and dentists are also considered primary healthcare providers. So the general practice of dentistry is considered primary healthcare. Primary healthcare also reflects public health, and there's three components and elements that are worth considering, at least from my perspective. It's about providing integrated health services to individuals and families at the primary care level that also connects through public health functions. Primary healthcare also addresses broader determinants of health, including social determinants and environmental determinants, by implementing evidence-based healthcare practices and policies. And most importantly, primary healthcare is about empowering individuals and families and communities to be engaged in making decisions that align with their own needs and beliefs that promotes and protects health and well-being. Primary healthcare and public health collaborate better. And this is the sandbox where I think oral healthcare and dental public health can play together and with others to make an important contribution to advancing oral health. Big picture, the big overall health picture from a global perspective is that primary healthcare and universal healthcare will work together synergistically to improve population health. This is all part of the Sustainable Development Goals that the UN implemented about 15 years ago. And primary healthcare, universal healthcare has a direct impact on the Sustainable Development Goal number 3, which is right here. Working together, primary healthcare and universal health coverage can improve population health. Universal health coverage is something that is important. And we see that with regards to the WHO Global Strategy of Health, the recent action plan has a vision for universal health coverage across all member states by 2030. In the United States, we have some of our population, if we split it out by demographics, practically has universal health coverage. If you're a child or an adolescent, almost all children and adolescents in the United States have universal dental coverage to some form, whether it be private player plans, public plans. These children and adolescents are covered for dental care. On the flip side, when we look at older adults, we have a long ways to go to advance universal dental coverage for them. So circling back, and if you recall earlier in the presentation, I mentioned about why it's important to understand a couple of concepts. Even though safe and effective measures exist to improve health and prevent disease, not everyone benefits in the United States. And it's important to recognize that everybody in the United States experiences oral health differently. And that benefit is because of policies and differences in policies. It's not necessarily related to the technology that we have today. So overcoming challenges to advance oral health law, that we need to recognize that every American experiences oral health differently. Depending upon your age, as I mentioned before, you have different access to care issues. Our dental care system is transforming and the system is stressed, and this is going to impact oral health. And we need better recognition of that. Advances in healthcare technologies, especially as they are applied to precision oral health care, often does not benefit people equally or equitably. And saying dental care is essential is not enough. We need to begin looking at how can we integrate oral health care into primary care? How can dentists be considered part of primary care infrastructure? This has the potential to improve the oral health experience by empowering, facilitating person-centered care, by integrating healthcare and care coordination, and how dental care can be there across life from young to old. So if anybody's interested in helping to escort Ralphie across the football field, there'll be a sign-up sheet at the presentation. It could be exhilarating, not quite like running with the Bulls in Spain, but it's exhilarating. But speaking of mascots, this is still my favorite. Thank you.
Thank you, Dr. Dye. We will now open up for questions. Please feel free to type your question in the Q&A chat. And for the first question, Dr. Dye, the participant says there is a growing advocacy for a transition from EDR to EHR to support integrated delivery of services. Can you please comment on the potential cost effectiveness of such transition?
Sure. Well, the cost is almost prohibitive when you're in solo practices. But as we're moving towards group practices and especially more corporate ownership, we're going to see this transition happen. Dental schools, actually, most dental schools have some form of electronic health record. Either it's connected through with the medical record, especially if they're an Epic, or there is the beginning transition where some of the Axiom records are connected to the broader enterprise. But the power is not what the upfront cost is. The power is going to be being able to help the individual patients that are in that group, in that record, so that we will be able to assess their overall health conditions and help identify areas where they navigated quicker, where we can identify problems earlier, and where dentists and physicians can work together better and collaborate more in a professional way.
Thank you. The next question, what role do you see the use of diagnostic codes amongst the dental community to better improve understanding of dental health in our communities, as well as better to integrate dental into primary health care?
Well, diagnostic codes are very important. We will see the implementation of diagnostic codes pick up as the electronic dental record gets integrated into an electronic health record. That will be a given. And I think the challenge is right now is as the profession is in this transition, there's a lot of hesitancy about what do we do with regards to the current record system, the current EDR, and then what will happen when we make that transition from the EDR to an EHR. So I think I'm a big proponent of diagnostic codes, but I don't see the implementation of diagnostic codes accelerating until we can move into the electronic health record space.
Dr. Dye, do you mind sharing a little bit about what you envision with respect to AI? I know you mentioned it in your presentation, but what do you see as some promising practices or on the horizon as it relates to artificial intelligence?
Sure. One area where artificial intelligence has great promise is screening images, screening digital radiographs. So you could, for instance, have a whole series of panoramic films, digital panoramic films, and you can push those through an algorithm that will screen for particular issues that we may miss. And this can happen in the background. And then it can flag a particular image for the provider to look at more closely. Screening images is like the in vogue thing across medicine. Many different medical specialties now are implementing different ways of how they can quickly screen images, reduce the amount of time that a provider looks at the image, and then if something is flagged, drawing attention to that so that the provider can come back and look at that image more closely. Screening images also, the AI piece of it is very beneficial because we can run that in the background and we do not need a provider and to be engaged in that at that point in time. So every single, for instance, in dentistry, for instance, in your practice, if every single panoramic film was screened and processed through an AI algorithm while you're at home sleeping, from what you did the day before, and you come back into the office, you could see that image could have been flagged, for instance, to redirect your attention to for closer inspection. So I think when it comes to AI, we're going to see a lot of advancements with regards to screening images, potentially screening records to help identify where certain individuals might be at higher risk for a health condition, for instance, being pre-diabetic. These types of areas is where we will see AI. And then we also will see back on the care pathway side, how does AI help inform clinical practice guidelines, helping to provide typical care pathways, for instance, for providers to consider.
Okay. The next question is, how can dental public health professionals address the shortage of service providers in dental health professional shortage areas?
That's very difficult. I think we will always be challenged with regards to the providers, the economics providing care in many of these professional shortage areas. Sometimes these economics does not align with the mechanisms and the infrastructure that we have. So I think from a dental public health perspective, it's really going to require innovative policies. It's going to require thinking outside the box, and it's going to require recognition that if we want to be able to provide providers in certain areas, then we're going to have to make a substantial financial investment in order to encourage providers to work in those areas. We're not there yet. We do not have the necessary incentives in place to help providers work in those areas. Even if they want to, it's still financially prohibitive for them to.
What are the things that we can do to become part of essential primary health care team? And are there any suggestions on strategies that can be implemented?
Well, that's a good question. And I think that's a good residence project. I would love to be, I think that we, as a dental profession, we need to be able to better articulate that we are or should be considered primary care providers, and we should work more closely with family practitioners, with geriatric geriatricians and with pediatricians, and work more closely in that primary care space with them. I think once we can elevate the recognition among our medical colleagues that dentistry should be considered part of primary care, it will be easier. The integration piece will be easier.
Okay. The next question, do you see a day when we will teach oral health in schools? And by teaching, the participant says that going beyond a once per year visit and explaining how to brush your teeth or oral health practices.
So like in schools, like in elementary school,
yes,
secondary school?
Across the board, yes.
Well, I think that's always a possibility. We can always expand the way that we advocate for oral health, moving beyond basic toothbrushing or trying to have a dental visit every 6 months or every year. I think that the issue, though, is, again, these are all like local driven initiatives. So it requires people who are passionate about oral health to be engaged with the schools and try to figure out ways of where they can expand a little bit more with oral health education.
Okay, next question. What do you think the role of dentists in achieving universal health coverage of dental services? Do you have any thoughts about whether U.S. dentists are accepting of universal health coverage or against it?
Well, that's a good question. I would say that our experience in this country with the expansion of children to the point where we have now almost universal health care has been well received, even though a good part of that expansion has been through Medicaid and through the ACA. But I think most dentists recognize the benefit of having somebody coming into the office who is insured, who has some form of health insurance coverage. Our practice of dentistry is going to be changing, and we're going to be moving away from the fee-for-service model. I mean, that's a given. And so at some point, in the future, we need to recognize and we need to embrace this transition. I think with the conversation around Medicare and expanding Medicare to have oral health benefits for older adults, it's an important conversation, but there's also important caveats, because it took a while to expand coverage for children. It didn't happen overnight. If we had rapid expansion of older adults into having something close to universal dental coverage, our delivery care system would not be able to support that now. We do not have the dentists who are trained in order to provide appropriate level of care.
Okay, is there anything that can be done to reduce the cost of dental education, in your opinion?
I wish I could say yes, but there isn't.
Okay, and do you ever think that dental care services will be provided under Medicaid for adults 21 and older?
Well, the direction for that happening is slow. That's going to be, every state is going to make that determination. But I would say that the trajectory for that occurring is happening. It's been very gradual, but at some point, for us to be, if the United States wishes to achieve universal health coverage for dental care, we're going to need some form of expansion with regards to public coverage. What that looks like, I don't know. It could be through Medicaid. It could be through some other instrument. It could be through Medicare. It could be through anything. But the issue is going to be that the public sector, the government, is going to have to play a greater role in helping to ensure that adults, working age adults and older adults, we get to the point of where they benefit from universal health coverage for dentistry, for dental care.
Okay. And Dr. Dye, before we go to the last question, I would like to go to the next slide just to promote our next webinar lecture. And that will be, our featured speaker will be Dr. James Taylor, who is the Chief Dental Officer of Canada. And that'll take place on May 24th. And that will be on a Wednesday. And once again, please subscribe to the Dental Public Health Residency Program email series, and the link is listed here on the slide. Once again, I want to thank Dr. Dye for his time today. We have maybe about one more question, if we could, really quickly. You mentioned that some states have more expanded functions and scope of practice for registered dental hygienists and also for dental therapists. Do you have any information showing if those states have better measurements of access to care? And what are the ways you can measure access to care?
Well, so we really don't have any data right now with regards to like dental therapy, other than what has been done in Alaska and tribal communities. Minnesota is the only state that's more advanced with allowing therapists to practice. So over time, I'm sure more information will be coming with regards to for dental therapy. looking at dental hygienists and looking at the range of scope of practice, a lot of it I would say is anecdotal with regards to how access to care has been improved. But what I do think is interesting is if states have large expanded functions capabilities for dental hygienists, then these particular states, like the 5 that I mentioned, also have authorized dental therapy to some extent, even though all those states but one really has practicing dental therapists. It's not clear if expanding functions for dental hygienists improves access to care and reduces the need for dental therapists, for instance. So I think that's an important question, because when you have large expanded functions, dental hygienists, they function like a mid-level provider, very much similar to, say, what a dental therapist is, with regards to like one particular distinction. Therapists can do more basic restorative procedures and maybe a simple extraction. So I don't know. I think, this is an area for research, and it'd be good for us to know.
Thank you, Dr. Dye. Once again, I want to thank you on behalf of CDC Division of Oral Health for being our presenter today. And we thank all of the participants that tuned in today. I also want to acknowledge Mr. Callahan and Ms. Kilpatrick and Ms. Brailer for setting up all the logistical aspects of this webinar platform. And once again, thank you again, Dr. Bruce Dye, as well as all of the attendees. Have a great rest of the day and great rest of the week.